Welcome back everybody for another video on urinary incontinence. In this video, we're now going to talk about one called stress incontinence. So remember, incontinence or urinary incontinence is essentially talking about an involuntary leakage of urine. So when we say we have urinary incontinence, which I'm abbreviating as UI, that is essentially an umbrella term that covers three main types of urinary incontinence, including overflow, stress, and urge incontinence. There are some other types. There's even like mixed incontinence, but those are the three high yield ones that I really want you to know for step one. So the problem in this disease is that we have involuntary leakage of urine due to two primary reasons. One of those includes urethral hypermobility, and the other is intrinsic sphincter deficiency. Urethral hypermobility is referring to a loss of our pelvic floor muscles or the connective tissue, which leads to an overall weakening of the pelvic floor. Why is this important? Well, it's important because if we have a weakened pelvic floor, the urethra might lose its ability to actually close completely. So if we think about it and we look at our drawing, in a typical healthy urethra, urine would exit the bladder and be excreted from the body. And at the end of this process, our urethra would actually close off, essentially blocking the further flow of urine through the bladder. This is important, right? Because when a patient leaves the restroom, they want to be done with the urinary process. They don't want to continue the process after they've left. So the body has ways to essentially shut off these physiologic processes from occurring outside of the area that we would like them to occur. However, in patients with this condition who have what we call hypermobility, their ability to shut this off and actually block further urine flow does not work quite as well. And so now we might have a scenario where a patient goes to the bathroom, they are urinating, and the urethra is supposed to cut off this system and actually stop the urination eventually at some point, but it doesn't do it as strong as it would in a healthy bladder. And so because of that, we may only get a smaller obstruction, but it still leaves way for some leakage of the urine. Rather than completely closing off the urethra, we partially close off the urethra, and this can lead to stress incontinence. The other primary way that patients can get this is due to intrinsic sphincter deficiency, and this is most commonly related to increase in age, pelvic surgery in either males or females, or trauma. And overall, the constellation of either one of these causes can lead to urine leakage with increased intra-abdominal pressure. So remember in the last video, the main thing I told you to take away from overflow incontinence was that those patients have a distended bladder without an urge to urinate. Well, here, the key thing I want you to remember is this increased abdominal pressure. So anything that increases the stress or puts more pressure on the abdominal cavity is going to increase the likelihood that a patient experiences symptoms from stress incontinence. So if we think about our presentation here, we're going to think about things that increase stress in the abdominal cavity. So these kind of things include coughing, laughing, sneezing, lifting, or definitely pregnancy, right? So anything you can think of that would increase abdominal cavity pressure is going to increase the risk of stress incontinence occurring in a patient who is predisposed. And by predisposed, I mean they have one of these factors that would lead to this occurring, such as the urethral hypermobility or the intrinsic sphincter deficiency. So a fairly classic vignette that they might give you is talking about a female patient who has previously had 3 vaginal deliveries, and now they're presenting with these signs of urinary leakage. Because they've had multiple vaginal deliveries in the past, they're at a higher risk of having pelvic floor muscular or connective tissue abnormalities or changes over time. And because of this, they're at an increased risk of stress incontinence. So as to say, the classic vignette would wrap up with saying, a 34-year-old presents with a history of 3 vaginal deliveries. The patient reports increased frequency with intermittent urination during particular activities. Those activities might include things such as laughing or even sneezing. And they could ask you what's the diagnosis in this patient, which is most consistent with the stress incontinence. Or they could ask you for what the best next step would be. And the diagnostics of this include a bladder stress test. This is sometimes also called a urinary stress test. And what this is essentially you have the patient do a Valsalva maneuver, which recalls trying to get the patient to kind of hunker down or do a forced cough. And this is a mechanism that actually increases our abdominal stress and our abdominal pressure. And we said, what happens to these patients when we increase their abdominal stress and pressure? Well, they should get some of the leakage of urine that they're experiencing. So if this occurs, this is considered a positive bladder stress test, also known as a positive urinary stress test. Additionally, another key differentiating feature I want to point out about these patients is that they will not have an urge to urinate. And do you remember what other type of urinary incontinence that we talked about also presents without an actual urge to urinate? That's right. Overflow incontinence also does not present with an urge. The one that actually presents with an urge is the urge incontinence. This is an important distinguishing feature because sometimes a lot of these patient presentations will kind of overlap with each other, right? They'll talk about a patient who is experiencing inopportune or involuntary urine leakage. And one of the key distinguishing factors is, does this patient feel the urge to urinate before it actually happens? Or is this just happening and the patient is noticing after the fact? So I want you to keep that in mind also. When we talk about management options, we're really talking about symptomatic management. And so because we said this is due to weakening in muscles in the pelvic floor, it makes sense that we can strengthen the pelvic floor muscles by doing things called Kegel exercises. Kegel exercises are essentially a constellation of therapy exercises that can strengthen the pelvic floor and thus decrease the patient's symptoms. We can also consider doing things such as a pessary, which is a pelvic organ support. This is a device that's made of silicone or latex that can actually be inserted into the vagina to provide it with additional support, which can overall improve the patient's symptoms. We can also consider some other things such as weight loss or lifestyle modifications. If we have a significant increase in bodily tissue, this is likely going to increase our abdominal pressure, right? And we said anything that increases abdominal pressure can make the symptoms worse or make them more present for the patient. And finally, we can consider the mid-urethral sling procedure. This is actually a surgical procedure which acts to elevate the urethra and provide it with more support for the patient, hopefully decreasing their symptoms of stress incontinence. And finally, some key associations for these patients include a history of prostate surgery or other pelvic surgeries, and the reason is that this can actually damage the internal urethral sphincter. We talked about how pregnancy, including an increased risk with vaginal deliveries, can actually cause this as well, and the reason is that undergoing the process of childbirth can actually damage or weaken the surrounding structures in the urethra, and this can lead to actual damage to the internal urethral sphincter or just generalized pelvic floor weakening, and these are two things that are going to increase a patient's risk of having stress incontinence. Another association that they want you to know about is menopause, and the reason is that after menopause, patients have decreased levels of estrogen, which often leads to vaginal atrophy of the area. It's also thought that potentially lower estrogen levels are related to lower muscular pressures around the area, which can increase the risk of leakage as well. And finally, the last one we talked about was anything that can increase the intra-abdominal pressure, including obesity, is going to increase the patient's chance of developing stress incontinence. So in summary, the key points I want you to take away from this video are that there are two main things that can cause stress incontinence: urethral hypermobility and intrinsic sphincter deficiency. Things that damage the internal sphincter or things that can weaken our surrounding musculature or damage the tissues, such as these associations, can increase a patient's risk for stress incontinence. Ultimately, the pathophysiology leads us to have urine leakage with increased abdominal pressure, and so things that cause an increased abdominal pressure are naturally going to make the symptoms worse. We can do something called a urinary stress test to actually create this environment of increased intra-abdominal pressure by doing the Valsalva maneuver. If this reproduces the patient's findings, this is a good indicator that we're on the right path to getting the diagnosis of stress incontinence. However, it's important to note that if a patient does develop stress incontinence, there are a variety of different things we can offer them in terms of management options. We can do lifestyle changes such as weight loss. We can do some non-invasive interventions such as exercises or an pessary. And we can even do some surgical type procedures such as a mid-urethral sling. And so this is a multifactorial approach in terms of helping these patients with their symptoms. We talked about a classic vignette already with a patient who might have had multiple vaginal deliveries in the past. But keep in mind, there's a variety of different ways they can ask this question. And they're really getting at, is there something that happened to the patient that either damages their ability to retain urine or increases their abdominal pressure? If yes, then we're on the right path. One key thing that I want to point out here is not to confuse this with overflow incontinence, because remember, we said both of these conditions present with no urge. This is in contrast to urge incontinence, which does present with an urge. The key differentiating feature here between overflow incontinence and stress incontinence is how the patient is presenting. What is the patient saying to you? When are they experiencing symptoms? Are they experiencing after lifting up heavy boxes and sneezing? That's more indicative of stress incontinence. Or is the patient talking more about the signs and symptoms they are having around actually going to the bathroom? Are they having an intermittent stream, a weak stream, or urinary hesitancy? These are vastly different histories that the patient is giving you as a clinician, and you want to use these to kind of guide your reasoning in terms of which is most likely for this patient. Additionally, another key differentiating factor is the diagnostics we will use. A bladder stress test is assessing for stress incontinence, and do you remember what we would use to test for overflow incontinence? That's right, the increased post-void residual volume.